Hello, my name is Rosalina McCoy, and I'm a consultant in the Division of Community Internal Medicine at Mayo Clinic in Rochester, Minnesota. It's truly an honor to speak with you about our study, titled Severe Hypoglycemia Attributable to Intensive Glucose-Lowering Therapy Among U.S. Adults with Diabetes, a population-based modeling study, 2011-2014, which will be published in the September 2019 issue of Mayo Clinic Proceedings. The goal of our study was to estimate as much as possible just how many emergency department visits and hospitalizations there were in the U.S. specifically because of overtreatment causing hypoglycemia. Using population-level data from the National Health and Nutrition Examination Survey, or NHANES, we estimated that there were over 9,500 ED visits and hospitalizations for hypoglycemia due to intensive treatment, and which may have been prevented if patients were treated less intensively. Most of these occurred among older and clinically complex patients who were intensively treated at the same rate as younger, healthier patients, nearly 22% of the time, despite the fact that guidelines clearly recommend that such clinically complex patients not be treated intensively. Importantly, such treatment predisposes patients to harm, both from hypoglycemia and other adverse effects from therapy, yet has not been shown to meaningfully improve their health outcomes. To conduct the study, we used a two-pronged approach and two different data sets, with each data set containing some but not all of the information needed to answer our question. First, we used population-level data from the Centers for Disease Control and Prevention, collected as part of the NHANES survey, to identify just how many adults have been intensively treated between 2011 and 2014. When we did this, we separately considered whether people were clinically complex or not, with clinical complexity defined as being 75 years or older, having end-stage kidney disease, having substantial functional limitations in activities of daily living, or having 3 or more chronic health conditions. We found that nearly 22% of both clinically complex and not clinically complex people with diabetes were treated intensively. Then, we relied on estimates from our earlier study on the rates of hospitalizations and emergency department visits for hypoglycemia with intensive as compared to non-intensive glycemic control. That study was conducted using Optum Labs Data Warehouse, a data set of commercially insured and Medicare Advantage beneficiaries across the U.S. In that study, which was published in 2016, we found that the risk of severe hypoglycemia was increased by nearly 80% when clinically complex patients were treated intensively. So when we applied this information to our NHANES-derived U.S.-based cohort, we found that there were at least 4,774 hospitalizations and 4,804 ED visits directly attributable to intensive treatment over a 2-year period. Severe hypoglycemia is a common, serious, and often preventable event in the management of type 2 diabetes. There are many reasons why a person may experience hypoglycemia, and a number of risk factors that predispose people to these events. Some of the common risk factors are older age, having multiple or serious health conditions, treatment with insulin or sulfonylurea medications, or irregular meal times or inconsistent meals. However, another important risk factor is intensive treatment, and this is something that we as clinicians have control over and can address. So it's important to individualize the management of every person with diabetes, recognizing that there's no one-size-fits-all approach to lowering blood sugar. Older patients, patients with multiple or advanced comorbidities, or with limited life expectancy, would benefit from a more relaxed glycemic targets and from simplified or de-intensified glucose-lowering regimens. Clinical practice guidelines advise targeting hemoglobin A1C levels less than 8 or even 8.5% for clinically complex patients. Yet in our study, we found that nearly 22% of such patients were treated with multiple glucose-lowering medications to achieve hemoglobin A1c less than 6.5% or even less than 5.7%. As clinicians, we need to identify potentially overtreated patients and consider deprescribing, which can reduce the risk of hypoglycemia, lower costs of care, and reduce the burden of treatment. I think this work is informative for patients as well. First and foremost, patients need to tell their clinical team about any episodes of hypoglycemia that they experience. We know that patients often don't share this information with their treating clinicians, assuming that the hypoglycemia is an unavoidable fact of life with diabetes. But if we're not aware that hypoglycemia occurred, we can't identify the reasons for why it happened and take steps to prevent it. It's also important for patients to feel empowered to engage with and sometimes even challenge their clinicians. Ask them about the pros and cons of treatment decisions. Finally, I urge patients to trust their clinicians if treatment de-intensification is recommended. Doing less can be hard to accept sometimes, but while lowering blood glucose is important, and when lowered to levels between hemoglobin A1c 7 to 8%, this can reduce the risk of diabetes complications. But lowering hemoglobin A1c and blood sugar too much can be harmful. Motivated by the high rates of intensive treatment among older and clinically complex adults that we saw in our study, as well as the emerging evidence that younger, healthier patients are too often undertreated at the same time, we're now working to develop an indicator of appropriate diabetes management. This measure would identify patients who are both undertreated and overtreated, and ultimately facilitate their treatment intensification or de-intensification, depending on what is necessary and best considering their clinical situation and context. This indicator would be individualized based on each patient's age and health status to ensure that we provide the right care to the right person and at the right time. We're also working to raise awareness about hypoglycemia and its prevalence, its preventability, especially in type 2 diabetes, and the harms associated with it. While there has been a strong focus on lowering blood sugar to prevent long-term diabetes complications, less attention has been paid to avoiding hypoglycemia. I believe that for patients treated with hypoglycemia-prone medications, particularly when they are at high risk for hypoglycemia due to their age or comorbidities, we need to routinely screen for hypoglycemia, almost like a fifth vital sign. And I hope that someday we will be able to make that happen. The most important takeaway message from all of this is that hypoglycemia is common, serious, and potentially preventable if high-risk patients are identified and if we as clinicians act to identify and reverse the causes for their hypoglycemia. Thank you so much for your attention. I hope that you read our study and find it useful in your clinical practice.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.